Good morning, good afternoon, good evening, everybody. Welcome to our ALTO webinar series. My name is Carlos Ortega, here with the Endologix team. I want to welcome you to our ALTO webinar series. This is the first edition of a series that we intend to dedicate to our ALTO device, which is currently launching globally. Today, I'd like to welcome Dr. Lyden and Dr. Holden to provide a bit of their early experience with the Graft and where polymer sealing technology has a role in their clinical practice. Just a little bit of housekeeping before we get started with Dr. Holden. We will be having a Q&A session at the very end of the presentations today. Just to manage the number of people we have registered for the call today, we'll be fielding those via our chat function. So if you do have a question for any one of our panel members or us here at Endologix, please feel free to field that through the chat function as part of the webinar here. So with that, Dr. Holden, I'd like to invite you to the stage here and just let us know when you'd like us to advance the slides. Thank you.
Yeah, thanks very much, Carlos, and thanks for the opportunity to participate in this ALTO webinar series. Next slide, thanks. So I'm going to present a case before we hear from Sean by way of, I guess, extending our experience on first-in-human work with ALTO. And this is the first commercial implant that we got to do a little time ago in Auckland, New Zealand. Next, thanks. These are my relevant disclosures. So this was a 72-year-old male, a 57mm aneurysm picked up on some imaging for some non-specific abdominal pain. As you can see on the initial angiogram, looked to have favorable anatomy, but the external iliac artery small, and particularly the right external iliac artery was very tortuous. So the low profile ovation ALTO system looked particularly good for this particular indication due to the small access arteries. Next slide, thanks. So I know that Sean's going to talk more about this, but ALTO really represents a very significant improvement and modification of the ovation series. What, of course, one of the key components is that the polymer sealing ring has been shifted to lie very close to the proximal end of the graft, so that the middle of the polymer sealing ring is only 7mm below the top of the graft material, and the graft material lies immediately below the radiopaque markers that are on the suprarenal stent. What this does is the graft deployment is much more intuitive in that you can really get a very confident seal into healthy tissue very close to the renal arteries. And this has implications for a number of anatomies that you can think of, hostile necks, and I think particularly conical necks, where the sealing technology and secure fixation of ALTO makes this a particularly appealing technology for conical necks, and maybe we can discuss that a little later on. Next, thanks. So, as I say, this was the first commercial case, but we were lucky enough at Auckland to do a series of cases as the first in human experience. And actually the very first case you can see in the images here was one that Sean flew down and helped us with. It was great to have him as part of the team there, and all those cases did very well, and that's been reported and published, as you can see. So we'll get on to a little video showing the case presentation on the day of the procedure. Next, thanks.
Good morning. I'm Andrew Holden from Auckland, New Zealand, and it's a pleasure to be just about to start an ovation ALTO case here in Auckland. We were very lucky to do the first in human experience with ovation ALTO, had some excellent early experience, and this is our first clinical case. It's a 72-year-old male patient with a 57mm diameter abdominal aortic aneurysm that was picked up incidentally on some imaging. His anatomy is certainly non-hostile infrarenal neck, but he does have some iliac artery access issues, and we'll do some angiography to evaluate those. I think in particular the external iliac arteries look small caliber and diseased, which is an excellent indication for the ovation ALTO. So look forward to showing you some of the procedural steps on the procedure we're about to undertake. Thanks very much.
Okay, next slide, thanks. So the device introduction, remember this is a 15 French OD device, and I'm actually just pointing to the deployment knob, and that marks, excuse me, marks the orientation of the ipsilateral limb. So in this particular case, we're actually planning to have the ipsilateral limb crossed, and we use general markers, the position of that knob. Now you'll notice that this is, as I say, 15 French OD, very low profile. Those external iliacs still were challenging, and really I think many devices would have struggled to deliver, but we could get the graft up into position very nicely, and we used that knob as a general positioning to reverse-oriented limb. Next slide, thanks. Once we've got the graft in position and the orientation corrected, we have the graft material several centimeters above the landing zone, and then we deploy the mid-crown segment that you can just see there. Now, the mid-crown segment has the radiopaque markers at its base, and remember the graft material is just below those RO markers. Now, there's no hooks or barbs being exposed here, so the mid-crown segment is deployed, and we're going to expand the mid-crown segment using the integrated compliant balloon. The volume of dilute contrast we use depends on the graft diameter. In this case, a graft between 20 and 26 millimeters, we put in 5 mils, I should say, of diluted contrast into the integrated balloon, as you can see, and this opens up the mid-crown segment, and you can see the RO markers are all nicely aligned. We use some cradiocaudal angulation to allow us to be orthogonal to the landing zone, and you can see we've got the RO markers very nicely all at the same level. So we're going to take care of any parallax issues. Next slide, thanks. We then have this integrated balloon that's not only used to open the mid-crown segment at the start of the procedure, but as you'll see, we also use it to mold the graft after polymer cure. And there are a number of other potential applications, such as in acute aneurysms and ruptures. But of course, having it integrated makes the procedure much quicker and keeps it very simple. And that's really been a very good advance. The other point I'd like to make is that top marker on the integrated balloon is a very important and accurate marker for the sealing ring. So we have the radiopaque markers for the top of the graft, but we have the top marker on the integrated balloon to mark the sealing ring. Next slide, thanks. So now we've just deployed the mid-crown segment, and now we've deployed the graft 2 or 3 centimeters above the landing zone, as I mentioned. And what we're going to do in real time is just slowly and in a very controlled way, using image overlay, reposition the graft into a caudal direction. So here you can see I'm just got complete control here, no hooks or barbs, minimal wall contact, and I'm in a very, we're maintaining that all the markers at the same level, so we've got no parallax. And see how easy that is to get very accurate on the renal arteries. You can see here the markers are still at the upper aspect of the renal arteries. Next slide, thanks. Here you can see an image of that. We get ready for our final repositioning. And you can see you've got complete control here. We could put those markers exactly where we wanted to. You can also see the top marker of the integrated balloon, and remember that marks the sealing ring. So we have complete control of where to deploy this. Next slide. So now we're going to do our final repositioning, and you can see it's very easy, millimeter perfect control. You could bring those markers a little proud of the base of the renal arteries because the material is attached to the bottom of those. And of course, the material may not oppose the vessel or the renal, so you could possibly even be a little bit higher than that. But we're in an ideal position there, and I've been impressed with how controlled this is. Next slide, thanks. So now we're going to do our final repositioning, and you can see it's very easy, millimeter perfect control. You could bring those markers a little proud of the base of the renal arteries because the material is attached to the bottom of those. And of course, the material may not oppose the vessel or the renal, so you could possibly even be a little bit higher than that. But we're in an ideal position there, and I've been impressed with how controlled this is. Next slide, thanks. Here you can see it's withdrawn into a final position. Next slide. And now we connect the, now we're really going to lock this position. So we use a second deployment knob to deploy the top of the crown, or the proximal crown. Now we have hooks and barbs fully deployed, so that graft is not going to move at all. So we had complete control of positioning, and now we've got very secure fixation. Next slide, thanks. Now we're going to connect the auto injector into the polymer fill tube, and you can see how well, as we fill the sealing rings and the proximal sealing ring, how well that radiopaque marker of the compliant balloon marks that sealing ring. It's exactly at that level, so you can see with great confidence we can deploy the graft knowing exactly where that is. Once the polymer rings are filled, I'm pulling the stiff part of the guide wire back into the delivery system just to improve the compliance through the sealing segment and improve sealing ring wall apposition as we do that. So we now start the clock, and the polymer is starting to cure. Next slide. We have 14 minutes to cannulate. I wanted to just illustrate here the use of the proprietary crossover lumen. So in 014 or 018Y, you can see the radiopaque marker going up and over the proprietary lumen. Actually, this wire went down the contralateral side, and that would make snaring and cannulation very easy. That was able to be achieved in a few seconds, but we decided to not use the crossover lumen. I just wanted to illustrate it in this case. Next slide. So just a couple of words about this proprietary crossover lumen, which is a very interesting and helpful development. What it really does, it means, as you could see in that case, with the use of a wire and snare, you've got very predictable cannulation times and increasing efficiency. You'll note also in the design of the graft that the two limb lengths are offset, so there's no confusion about cannulating the ipsilateral limb as opposed to the contralateral limb. Next slide. I decided to just use the conventional method of cannulation with a catheter in the contralateral side and up the contralateral limb. As you can see, they're offset limb lengths, and then introduce a catheter up. Next slide. An angiogram to confirm that we're in the graft. Next slide. And now we're going to deploy the contralateral limb. Now we're still within the 40 minutes of polymer curing. Obviously, if cannulation had been a little longer, you wouldn't proceed with this step. You'd deal with the ballooning of the top end, but we still had time. Next slide. So we deployed the contralateral limb, having used the calibrated catheter to predict an accurate length. And it's a pin and pull deployment as many other grafts, and are very easy to get very accurate with that deployment. Next slide. Here you can see a single view of that. Next slide. We then had hit our 14 minutes of polymer cure, so we used the integrated balloon, and you can see we just inched that balloon up a little bit so that we're actually got the balloon right through the sealing zone, and just optimizing the seal at the time of polymer cure. Next slide. And now we deploy the, play that slide, thanks. Now we deploy the ipsilateral limb. You'll notice that the ends of the two limbs are deployed between the top. If you could, oh, that is playing, it's just playing slowly, I think. You can see that the two limbs are deployed at the same level, and somewhere between the top two rings, sealing rings of the limbs, is where we aim to deploy the top of those limbs. If we need to shorten once the graft is below the sealing ring segment, we can just push up on the graft, as you often do with limbs, to optimize landing at the distal end. Next slide, thanks. Completion angiography, we were happy with those appearances. Next slide. And if we just play the CT, if you play the axial CT done 3 or 4 days after the procedure, you can see the sealing ring, and then the graft, still a little bit of gas in the aneurysm sac, but otherwise a very pleasing appearance. And if we play the volume rendered reconstruction, just rotate the right hand image, you can see a very nice appearance. Next slide. So patient made an uneventful recovery and is doing well. I think obviously ALTO really has a very unique design in that it's a polymer sealing technology combined with very secure fixation that provides a very durable seal. This particular case was pretty straightforward anatomy, although the external iliac arteries were narrowed, and that was excellent for the low-profile device. Obviously, real-world experience is continuing to be gathered, and very excited to see a very rare randomized controlled trial in EVAR, the ALTO randomized controlled trial, which is estimated to begin enrollment sometime in the remaining part of this calendar year. So thanks, Carlos. Over to you and Sean.
Thank you very much, Dr. Holden. That was a great presentation. Thank you for walking us through your first case. Very exciting to see the results. As we transition here over to Dr. Lyden and promote him to be a presenter, I think our upcoming speaker obviously doesn't require any introduction, but you know, Dr. Sean Lyden at Cleveland Clinic. He's going to walk us through obviously his early experience, especially with the Elevate data, which is the IDE trial for the ALTO device. So, Dr. Lyden, can you hear us okay?
I can. Hopefully you guys can all hear me.
Yep, and we're seeing your presentation loud and clear. Thank you.
Perfect. So first of all, you know, I'd like to say that when I first got approached by Endologix to be the national PI for the Elevate trial, I was eager because having been a user of the Ovation device, my biggest complaint was it didn't allow us to treat shorter necks, and a lot of the things that we had complained about the device in terms of fixing the ability to treat shorter necks, finding was coming to fruition. But just like any good investigator, I was really nervous before we got to started here in the US. And so when we were able to do first in human implants in New Zealand, I found out about a week ahead of time. And so I literally got on a plane, flew to New Zealand, got off a plane, and 6 hours later, I'm in Andrew's lab watching him do the first two cases. And let me tell you, he's a very slick operator and a phenomenal host. I was in New Zealand for all of 32 hours, and I got on a plane and another 36 hours back to Cleveland. And so I was pretty eager to see this, but Andrew makes it look a lot simpler than it is when we, you know, hadn't used this in anybody yet. The first two cases in the first in human trial just went as flawless as could be. And I would say that his second first in human case looks like my seventh case, which I'll show you, which was my second commercial case. But we did some really pretty tough first in human cases. So these are my disclosures. I'll let everybody a chance to look at those. So we're first going to sort of talk about the Elevate trial. And so this was the U.S. pivotal IDE to allow for U.S. approval of the ALTO device. And it involved 75 patients across your 12 centers. And we were able to actually do this trial in under a year. We started in March of 2017 and then finished in February of 2018. To be allowed to be treated in the trial, you had to be at least 18. We had the exact same criteria that every endograft trial has, as mandated by the FDA. Have an aneurysm greater than 5 centimeters, or an increase greater than a half centimeter within 6 months, or a max diameter 1.5 times the adjacent normal aorta. Just like the Ovation IX trial, you had to have adequate iliofemoral access. Many of the other trials have had specific diameter requirements for access and have had caveats for calcified access. Because we were using the IX limbs that were commercially approved, really just trying to study the proximal component, we used the exact same adequate access for that was done for the Ovation original trial. The neck diameter has to be between 16 millimeters and 30 millimeters, but unlike other devices, really you just have to know what the diameter is at 7 millimeters below the lowest renal artery. And Andrew said that really allows some treatment of conical necks that would otherwise be off IFU from other devices. The two things, because it has a suprarenal component, just like its predecessor, you could only treat up to 45 degrees if the neck was exactly at 7. If the neck was 7 or more, you can treat up to a 60-degree neck. The iliac landing zone was basically constrained by the diameters of Ovation IX available, so you could treat between an 8 and a 25 millimeter vessel, and you had to have at least 10 millimeters into a common iliac artery. So as Andrew talked about, a couple of key things of this device that's separated from the prior device is, number one and most important, that sealing ring goes from 13 millimeters below the top of the fabric to 7. The second thing they did is they increased the webbing at the bifurcation to make it easier to cannulate, and they offset the aortic body legs to be able to tell which one is which. and then it also kept its low profile anatomy. So if we look at the two devices here together, you can see the Ovation IX device next to Ovation ALTO. When you make ALTO and move that ceiling ring up, one of the things in order to do that is the nitinol rings that sit within the Ovation IX device had to be removed. And so Andrew showed you the picture of those tethers of PTFE that then hold the suprarenal fixation in place. You can see the increased webbing between the legs and how now the contralateral leg is 5 millimeters longer than the ipsilateral leg. The other thing that I didn't get at first, and having been a part of endograft trials since I was a fellow in 1999, it had an integral balloon. And for those of us who are quite old, I see Jim McKenzie on the call, when we first got to use the Talent device, the original Talent device had a balloon in it, and I had very bad memories of what I nicknamed as a fellow as the femoral artery disruptor device. Now, once I got to understand the device and realized that once the nitinol ring was removed from the ceiling segment, the device doesn't open up on its own, and so now you have to put the integral balloon back in it. But the nice part of it is I was always been a believer that I'd rather balloon than not. So having the balloon built within the delivery system has parenthetically made it way easier to do the entire procedure. The other key thing, as opposed to many other devices, you can see the markers, the RO markers, are above where the fabric starts. And so you can really leave those RO markers within the renal artery and know that the fabric is always below it. As Andrew showed here, it looks very much like the Ovation IX device, except on the back side there's a balloon port. And Andrew was showing how the yellow points to the ipsilateral side. I'm a much simpler person. I remember green equals gate, so the gate's on the green side. So instead of yelling yellow is the ipsilateral side, I remember green is gate. Plus I'm Irish and I like the color green. So if we look at it, they're now all 15 French outer diameter. And one of the other changes was you didn't need as much pressure in the auto injector. So the old auto injector was a blue auto injector. It was a 2 PSI. This one's green at 1.5 PSI. And they maintained the integral crossover lumen that came out when the IX device was released. So if we look at the patients in the trial, the average patient was just under 74 years of age. Most were men, 93%. Most of them were quite sick, in ASA class of 3 or 4. 83% had hypertension. Only a minority had COPD, probably because we're bad at documenting it. Most had elevated cholesterol, 5% had chronic kidney disease, and 95% were current or former smokers, and just about half had coronary disease. The average AAA diameter was just under 5.2 centimeters with a standard deviation of 6.6, and the neck length range based on SVS definitions, which is the diameter of the lowest renal artery to a 10% diameter change, between 5 millimeters and 66. But really, to remember, with this device at IR7, you have to be between 16 and 30 millimeters of diameter. And the average neck diameter was 22 plus or minus 2.4. Technical success was described as successful device delivery, accurate deployment and withdrawal, whereas treatment success was technical success and 12 months freedom from type 1 and 3 endoleak, freedom from migration greater than 10 millimeter according to the SVS definition, freedom from aneurysm enlargement greater than 5 millimeters, which is the SVS definition, freedom from aneurysm rupture, freedom from conversion to open repair, freedom from stent graft stenosis, occlusion or kinking, thromboembolic events, stent fracture, or secondary intervention. So we look at the trial, the average procedure lasted 90 minutes median with an estimated blood loss of 52 milliliters, and 97% of the patients were discharged at home with a median length of stay of just over 1 day. If we look at the 30-day outcomes, there were no aneurysm-related mortalities. There were no all-cause mortalities. The major adverse event rate was 5.3%, with 100% technical success. There was one patient in the trial that had a type 1A endoleak. There were no type 3 endoleaks, and there were aneurysm ruptures. If we look at the predicate trial for Ovation Prime, about 3% of the patients had a type 1A endoleak that were treated commercially with a giant balloon expandable stent or a palmate stent. And so this trial, when it was created, we predicted that with the FDA. There actually was creation of a pre-mounted balloon expandable stent. Unfortunately, it wasn't ready in time for the trial to begin, so there wasn't one allowed. And one of the differences in prior trials, if you put a balloon expandable stent in with a device, that used to be a treatment success, but the FDA's definitions have changed and then it becomes a failure. If we look at their 12-month outcomes, treatment success through 12 months was just under 97%. The all-cause mortality was 4%. One patient passed away from lung cancer, one from a car wreck. The other one, it really wasn't known. So the Kaplan-Meier freedom for mortality was just under 96%. There was 100% freedom from aneurysm-related mortality. The major adverse events rate at 1 year was 10.7%. There was only one patient with an expanding aneurysm sac greater than 5 millimeters, or 1.6%, and 13 patients, or 21%, had a decreasing sac diameter. At 12 months, there were no patient with a type 1 or 3 endoleak, and remember this was a 12-month definition. As I noted earlier, there was one patient at the completion angiogram that had a type 1A endoleak that was treated successfully with a balloon expandable stent at day 48 that had remained resolved through 1 year. No patients had migration. However, there was one patient who had developed a systemic infection a couple weeks after their implant that infected their graft, and they were successfully explanted and did well. So we'll talk just for a second about the Cleveland Clinic experience during this trial. I was the PI at the clinic. We actually enrolled 6 patients. They were all my patients. Fortunately, none of my patients had any adverse events. None of my patients had a type 1 or 3 endoleak. None of my patients have had a growing aneurysm. I've had no migration and no fractures. We started this trial in 2017, and so now almost all my patients are coming back for their 3-year follow-up. This is one of my patients who's now at his 3-year follow-up that I just saw a couple of weeks ago, and he still has successful exclusion of his aortic aneurysm with a stable aneurysm sac size with no evidence of migration or endoleak. And you can see here's his aneurysm sac with the device sitting in it. So I've had 2 cases post-approval. I was fortunate enough to do the first 2 cases in the United States. The one thing I'll tell you is my advice to everybody is always start with an easy one. And it really, to remember, this wasn't my first one. I'd done 6 within the trial. So this was case number 7. It was a really easy case. I'll show you that case. And then my, which was my 8th case, what I'd say is a really pretty tough case and really shows what this device can do. So my first commercial case, if you looked at this guy failed the eyeball test. He had an above knee amputation on one side, a below knee amputation on the other side. He comes in a wheelchair. I actually saw him in the hospital when they had a retroperitoneal mass and a bunch of other things going on and a little hydronephrosis from a kidney stone. I let all that settle down, got a CAT scan on him, and lo and behold, he's got the world's greatest anatomy for an endograft. He's got this 17 millimeter neck at the lowest renal artery. It doesn't have a 10% diameter change until 48 millimeters lower. He's got a just under a 6 centimeter aneurysm. You can see here's at his right renal artery, and then here's several centimeters down, a nice parallel long neck. His iliacs are normal. They're 14.9 on the left, 13.2 on the right. And his access vessels would be considered small for some other devices, but for ovation, really pretty big access vessels at 7 millimeters on the right, 6.5 on the left. So here's from his procedure. You can see we have this really nice long neck. Getting the device in, as Andrew showed, deploying the first crown, using the balloon to sort of open up the device. And once the polymer is instilled and my limbs are placed, you can see that the device sits just basically dead into the renal arteries. And then I've seen him back already for his first month follow-up, and really his aneurysm is excluded. He has a small lumbar endoleak, but a really nice result. You can see here is at his renal arteries, and you can see actually the outline a little bit of the graft. You can see here's lumbar endoleak, but good sealing into the iliacs. So my case number 2 is a little bit different. I met this lady in November. She had come for a redo open heart at the Cleveland Clinic and had a really pretty rough course. She bled, had to have her chest re-explored. She had to have a persistent pneumothorax on both sides, had to have a pulmonary decort on both sides, and really struggled and was in the Cleveland Clinic for about 2.5 months. While she was in the hospital, we got a CAT scan, and we'll just sort of go through some of her anatomy right here. You can see her left renal artery is the lowest. There's a little bit of calcium, but her aortic neck is just under 22 millimeters. If you look 2 or 3 millimeters below that, it's still pretty good. But if you get down 7 millimeters below the lowest renal artery, it already has more than a 10% change. You can see it's now 26.5 millimeters. Her axis isn't the most favorable either. Her common iliac arteries are about 7.5 millimeters on each side. Her right external is 5.2, and her left external is 3.8. If you look at it in a MIP, here's looking at her proximal neck. You can see she really has a 7 millimeter neck. It then balloons out to 40 millimeters. It then narrows down to about 30 with a napkin ring, and then it's almost 6 centimeters. Here's it looking at from a lateral view. You can see here burden of atherosclerotic occlusive disease, that posterior bulge, intercalcified iliacs. And I think anybody who would look at this would think, not the greatest candidate for everything. One of the things we had talked about in this lady is potentially doing a zenith fenestrated device, but really in order to do that, she would most likely need, unless you have access like Jim McKenzie does to a physician-sponsored IDE and you get a preloaded system, you're really going to need to do conduits on both sides. And I really wasn't excited about doing that. With how calcified it was, I wasn't also excited about trying to do a unilateral conduit and then trying to use one of the other commercial devices with tacks. I really thought that was less than ideal. And actually, she and I had talked a little bit about waiting for the Ovation ALTO to come out. And so that decision really came in through February and March. And it looked like in March when they got approved it would come out. Unfortunately, because of COVID, it didn't get released until July. So we brought her to the OR in July, and this was my second case. And I've also seen her back, and you can see here on her post-op CT, you can see here's her lowest renal artery. You can see the outline of the sealing ring. And then here's on a MIP reconstruction, you can see how that device basically sits right at the renal artery. You can see how that sealing ring sits exactly in that small neck she has. You can see that she's excluded, and you can see that we've been able to get this up this very difficult small access person. So to bring it back to conclusion and sort of get to discussion, Ovation ALTO is clearly safe. It's effective in the treatment of aneurysms that have necks between 16 and 30 millimeters and measured at 7 millimeters below the lowest renal artery, and that data is through 12 months. I've treated 6 patients, and so far 4 of my 6 are back through their 3-year follow-up. There's been 100% technical success. The treatment success at a year was 96.7%. That includes the one patient with a type 1A endoleak treated with the balloon expandable stent and the other person who developed an infected endograft that I haven't explanted. There was only one patient with an aneurysm expansion. There was 20% of the patients with aneurysm decrease. There's been no migrations. And my really advice is I think that you can start with easy cases. My first 7 cases, 6 within the trial, 1 commercial, were really not that challenging. But I would say looking from the last case I did, which is really Andrew's second case, looked almost identical to this. I would say this device can be a game changer to mostly put it in necks that otherwise are not treatable with other commercial EVAR with challenging access. So with that, I'm going to go ahead and stop my presentation, and then maybe we can do a little discussion with Andrew about how he now thinks about this device and how he's looking at using it commercially. But I would say that the really nice part is that for someone who's treated with a commercial EVAR, this really could be somebody I can treat just about anybody in my practice. And this really, to me, expands what I feel I can do.
Thank you, Dr. Lyden. Really appreciate taking the time to walk us through that. That was a fantastic presentation. Just a kind reminder for those of you that are joining us today, if you do have a question, you could please submit those through the chat function. We could field those as they come in. But maybe to get us started, I think there was a nice segue, Dr. Lyden, on how you closed your presentation. Maybe you could spend some time, and then maybe Dr. Holden, hearing your comments too. What would be some key areas where you would focus or highlight for folks that are starting to use the device that you learned early on, whether it's through your previous Ovation IX experience and transitioning to ALTO as they join the technology for the first time? There's some lessons learned that you could impart or share with the group. That would be great.
So I'll start off just along that regard. I was a site for the Ovation Prime device, which eventually became the Ovation ALTO device. And while the Cleveland Clinic was doing that trial, we had a lot of commercial devices. And so when you have a lot of devices you're very familiar with and used to using, not surprisingly, I really threw patients in that trial that I couldn't treat with another commercial device because I had other devices that I'd used for a long period of time that we had 5-year trial data. And one of the things that surprised me about the predicate device was how this device would go up challenging anatomy. And it surprised me how accurate you could deploy it because of that double crown system. Really, the one thing I learned then was that I started using it in straightforward cases, and I found it really could be quite a versatile device. And I really was able to use it successfully in conical necks. I have patients I've treated with the predicate device now out more than a decade, really not having an issue. People say, well, what if you have to convert it? And I always say, if you're planning to convert an endograft, maybe you should do open surgery. The clinic has the world's largest experience with converting all devices. I've never had to convert one of my own patients, but I've converted other people's when they plan poorly with every device there is. And I would tell you that you can clamp the suprarenal device just like any other device, and it's not that, and leave that part behind and take it out. But I don't really think that's the way I'm planning for failure. And the one thing we had limitations of the device was, well, it worked really well, but you had to have that diameter at 13 millimeters below the lowest renal artery. It just seemed to be that if we could move it up closer to the renals, the device would be much more versatile. So I probably spent 7 or 8 years complaining to the engineers at Endologix that there's got to be some way to figure that out. And so that's why I was so excited when ALTO was first shown to me, and I was so excited to become a national PI to say, wow, you finally listened to us. You feel like when you talk to companies, they never listen to you, and you're like, wow, you actually listened to us and you changed all the things we wanted. And I was always a believer in ballooning to get your best chance to have that polymer mold and seal as you want. And so when I first saw the balloon in there, I thought back to the old days of talent and was sort of gassed. But the nice part is now if you're struggling to cannulate the gate, you got the integral crossover wires. You don't have to worry. You don't have to worry about putting a balloon up if you need to use it because it's already in the device. And so you don't have to get out another balloon. And I would say, as Andrew showed, the accuracy of placing this device is amazing.
Thanks, Dr. Lyden. Dr. Holden?
Yeah, well, I think Sean's made some great points. Just in terms of some of the key areas, I think one of the things, I mean, if we go back to planning, I think it's fair to say that the ovation earlier designs where you're trying to identify a segment so-called R plus 13, in other words, looking at the aorta, not at the level of the renal arteries, but looking at it 13 millimeters below that and making sure that you plan your grafts to land there was challenging. And you also needed to therefore concentrate on landing accurately as well as planning accurately. Having the sealing ring very close to the top of the material means that most of your pre-procedural planning and intra-procedural deployment is very analogous to your experience with other EVAR devices. So I think for clinicians who don't come into ALTO with an experience with ovation, they won't find the learning curve particularly large at all, and the management of the polymer is very straightforward and simple, and the auto injector is very easy to connect. So all of that is very simple. I think, therefore, you're looking at the immediate infrarenal aorta and measuring the infrarenal aorta, and therefore planning your graft size and deployment strategy very much like another EVAR device. I guess some of the other things I'd stress are, just like other EVAR devices, you need to avoid parallax. You need to make sure you're centered right on your landing zone, and you need to make sure you're orthogonal to the graft. And that is so easy to do with the RO markers of the device, and with the fact you've got this mid-crown deployment that you can very controlled bring back into position. So I must say that I have a lot of confidence with millimeter perfect deployment, and I actually disagree with Sean. I think my second case wasn't nearly as tough as that case he showed us, but he did a fantastic job with that. And you can see, had he not landed pinpoint accurate, he may not have got the kind of result that he got. So I must say I feel very comfortable and relaxed using that deployment strategy. And switching to the integrated balloon, I think the integrated balloon is obviously very straightforward to open up the mid-crown segment. I think the balloon molding at 14 minutes is also important. I like to see a slight hourglass shape with the balloon so that you've got the center of the around the sealing rings, but you're actually molding so that there's the balloon above and below it. So you're really optimizing your mold. And I think we saw in the Elevate series that if you use this technique, the combination of the position of the sealing ring, but the ease of use of the integrated balloon with more routine use means, and like Sean, I routinely balloon, means that we could expect to see virtually no type 1As, and it was pleasing to see that there was there was only one case, and had we been allowed to have managed that with a stent, I'm sure there would have been no post-procedural type 1As in the Elevate series. So those are just a few points to highlight.
Dr. Holden. Maybe I'll follow up here with a question to you, Dr. Holden. I mean, recently you were kind enough to participate in the Charing Cross Vienna Symposium, and in that symposium, Dr. Verhagen presented some interesting data around, wide necks and the durability issue that they present to EVAR patients, with obviously type 1 endolix being a big concern. And earlier in your presentation, you really talked about some anatomies with challenging, hostile necks. Maybe you could comment a little bit about, your view on polymer technology in that setting. And obviously, Dr. Lyden would love to get your thoughts here too.
Yeah, well, if we have a look at some of the most important information I think I've gleaned from EVAR technology in the last 4 or 5 years and reports of results, I think one of the things that's really was important for me and shifted practice was the 5-year durability results of ovation, combined reports of previous experience. And that's really around neck stability compared to self-expanding stent technologies. And so we know that self-expanding stents are associated with, in the sealing zone, are associated with ongoing neck dilatation. And we know that progressive neck dilatation is a predictor for long-term adverse outcomes. What we didn't appreciate is just how prevalent that is, where we're seeing, late neck dilatation and late failure at a significant percentage of patients who we follow out to 4 and 5 years. Whereas the neck has been entirely stable with a polymer sealing technology. And that really has excited me. It's meant that I would think of this kind of technology, polymer sealing with very secure fixation, as being applicable not only to the anatomies that we talked about that are obviously appealing, like small access arteries or conical necks, but actually, as Sean was saying, you can see applicability in much more routine use because we're changing the paradigm of care, and that we would not expect the late modes of failure associated with neck dilatation. So, I think if you're talking to patients who could be treated with any device, and you're saying, well, listen, we can now offer you this sealing technology as opposed to a device that involves stent grafts with self-expanding stents, I think we may well be able to actually say we think this may be offering you some extra durability. And obviously, it's really pleasing to see that we'll actually get an academic answer to that question with the randomized controlled trial. And once again, I applaud Endologix for doing that.
Any commentary on the setting or the polymer technology in the setting of wide necks or hostile necks and your viewpoint there?
So I didn't get the chance to see what was presented at the Vienna meeting, but I've had the pleasure of working with Mark Schermerhorn and Hans Verhagen, looking at the combined data set from all the world's experience with Ovation IX. It's called the Encore Registry. And we previously showed the lack of neck dilatation in that patient population, as Andrew just noted, the really low issue of light-term type 1 endolix rates for the absence of migration, the absence of aneurysm growth and rupture. And so right now, I just gave some edits back to them. And so we looked at disadvantaged necks, so both short necks by SVF definition, angulated necks, and wide necks, and really seeing that in the Encore series through 5 years, that really no difference in adverse events in terms of the risk of type 1A endolix migration or aneurysm rupture or failure associated with wide necks using the 34 millimeter device. And that's very different than the self-expanding stents. The clinic, we were probably 98% Cook devices through my first 12 to 15 years of practice, and I have great confidence in the Cook device. But I've seen with most every self-expanding stent graft that over time, with outward force against the wall, a lot of aortas will get to 1 or 2 millimeters of whatever device size you put in. We had access to the Cleveland Clinic to 36 millimeter devices with Cook, within a physician-sponsored IDE about 6 or 7 years before the rest of the country. And so when everybody else finally had access to 36 millimeter commercial devices, we were already seeing some of those patients with 30 and 32 millimeter necks that we put a 36 device in, that now are 33, 34, 35, and even 36 millimeters. And so they're already an aneurysm. And so I think now the literature is starting to catch up that wide neck devices with self-expanding stents are not the greatest idea. And I think that people who have had access to custom devices within physician-sponsored trials will all sit there and tell you those patients that they might have treated with a 36 device 5 and 10 years ago, now they're treating with branch and fenestrated devices because of trying to get into the normal aorta. I think the difference of the polymer sealing technology is because we've shown that the lack of outward force on the aorta doesn't associate with neck dilatation. You can achieve those same results without having to encroach upon going into the visceral and renal arteries. And really the only people that happens to are those people that just end up having a small thoraco that just hadn't grown big enough yet for all of us to know.
Great, Dr. Lyden. Thanks for sharing that. Yeah, I think the same information you were referring to from the Encore study is one and the same of what Dr. Verhagen presented. So thanks for commenting on that. Maybe a question for you, Dr. Lyden. You know, when we look at some of the data and the long-term durability that we see with EVAR and some of the first, seminal works against open surgical repair, and certainly we see some of those outcomes, from those early studies, which we could see are likely due to maybe some early devices or maybe not having the sophisticated imaging equipment we have today. But there's a lot of information that highlights the favorable outcomes that might come from, strict adherence to the instructions for use. I know you're a big proponent for that. I was wondering if maybe you could comment a little bit about, again, early experience and, kind of the on-label usage and just your overall view on maybe the applicability of the ALTO devices as we move that ring up, and certainly what it offers.
So being an institution where we had access to every research trial, we had access to building custom fenestrated and branch devices, also being in a tertiary care referral center where you got everybody else's sort of tough cases and everybody else's failures. I'd say when I first got here, we lived very often outside of the IFU with first the EVT anchor device, then the Aneurysm device, then with the Cook device. And I think what we always sort of found maybe 4 to 5 years before everybody else is what happened when you lived outside the IFU. I've had a passion for writing up about explant experience. It's only because we still salvage about half the patients we'd see with the branch or fenestrated solution, but not everybody can be fixed. And so one of the things we sort of come to at the clinic is really not trying to push the limits of what a device can do. And if you have a 5-year data set within a trial, if you stay in those boundaries of the trial, you can talk confidently to your patient that that's the results they can expect. And if you live outside of those instructions for use, it's generally going to work worse. Mark Shermer has written up the data from Medicare, and what we see that in Medicare, for all patients treated in the United States, there is a 8% risk of rupture at 5 years after being treated with an EVAR. And we know that a lot of patients are treated outside of the IFU. And so we've really retreated to trying to stay using appropriate devices within their IFU, and we've had access to ability to treat the whole aorta with endovascular devices, as well as still doing a lot of open surgery. But I generally talk to my patients about saying, hey, here's the boundary conditions of how a device was tested. If I stay within those boundary conditions, I can talk with confidence that this is what we might expect at 5 years. And we know for every time we go outside of those boundary conditions, we're less likely to have that kind of durable result. And to me, the really nice thing about ALTO is if you look at ALTO on label, based on how the device is designed, both treating challenging access, challenging short and conical necks, all on label, it has had great results through 1 year. And we know the 5-year results when that sealing ring's at 13 millimeters. And so really the only big change, if you want to think about ALTO to IX, it's moving that polymer sealing ring. And so the way it seals, the way it fixates, the way it resists migration, none of those things has changed. And so I feel pretty confident that we'll continue to see that same phenomenon out through 5 years. And all 6 of my patients, like I said, I've seen most of them back already. I have 2 more to come back. Through 3 years, they've all done fantastic.
Holden, obviously would love to hear your comments or any perspectives you have on the topic.
Yeah, no, look, I agree with Sean. I think, we do know that, IFU compliance is important, particularly when people are gaining early experience. Certainly, you would hope that clinicians early in their career would pay more attention to IFU compliance, and certainly we should try and do that where we can. Of course, in the real world, the anatomies, many of the anatomies we're presented with are outside of the IFU of many of the current devices. And unfortunately, the biggest components of that are related to the proximal neck anatomy. If you look at things like, as we say, core lab adjudicated conical necks, that is, where the neck length becomes more than 10 millimeters below the lowermost renal and so on, this is a very prevalent problem. And current devices, actually, it's really surprising, even amongst experienced clinicians, how there's quite a bit of disagreement about, how do you size for a conical neck and with a conventional EVAR device, which means how much oversizing do you accept in the less severely dilated segment cranially, and how much you are going to size or oversized distal. You'll find different answers from different clinicians, even very experienced ones, and a lot of that is not evidence-based. We are starting to get a little bit of evidence just in the last 12 months or so, but clearly conical neck is a very common problem, a frequent reason why patients' anatomy is outside of IFU, as is short necks. And I think if what we've really got here is some technology that's not going to treat all of these patients outside of, not going to bring them all within IFU, but it will bring a significant component of these patients. If you add in the fact that particularly with female patients and older female patients, access arteries is also another major challenge for IFU compliance, then suddenly I think you've got a technology where you can treat a number of the patients who otherwise were outside of IFU for conventional EVAR devices in those groups within IFU. And as Sean says, that then gives you confidence when discussing the options with patients and quoting some of the data that can be directly applicable to them. And I think that fills both the patients and clinicians with much more confidence.
Thank you, Dr. Holden. Appreciate your thoughts on that. With only 5 minutes left here in our webinar, rather than jumping into other questions, maybe I'd invite Dr. Lyden and Dr. Holden to have any closing remarks you have for the audience. Obviously for anybody that had a question for us today that we didn't get to, we're happy to try to get to those offline here. So if you do have a question and we've captured it here, we'll try to get out to you as soon as possible. Otherwise, obviously, your local rep is a good source for us to get you that information. So with that, maybe Dr. Lyden, I'll invite you to maybe with some closing remarks, and then Dr. Holden.
So I would say that looking through the trial data, it has really been very clean with excellent results. My own patients have done well. The really nice thing I could say about this entire series of devices, whether it was from the Predicate Ovation Prime, the Ovation IX, or now the ALTO, the company's done a really good job of listening to what people want. People had really didn't know what to make of polymer technology when it came out. They spent a lot of time getting data to show that the necks don't dilate, that with the suprarenal fixation, it doesn't fracture, the devices don't migrate. They shortened the polymer time from 20 minutes to 14 minutes. We asked to move the sealing ring up. They've been able to do that. People sort of struggled to cannulate the gate. They came up with this unique integral crossover system. And so if you don't like cannulating a gate, you don't have to. You can just put this crossover wire in. And so I think the really nice thing is we've seen these iterative changes, and we know 5-year results from the design, and now 1-year results for this modification by moving the sealing ring. And so I really look forward to, continuing to use this in my practice. And like I said, the predicate device, I have patients now out more than 10 years and 3 with this device. So I'm very confident that this is a great device and it works really well in my practice. And I have a much better time telling my patients that, because the chance of them being on IFU with this device is better than any of the other commercial infrarenal EVAR devices.
Yeah, Sean, great summary, and I would add to that. I mean, the reason I showed you our first commercial case is because we were excited to, having had the first in human experience with now 4 and 5 year results or 4 year results. Now we're seeing in these patients with durable results that we were really excited to get our hands on the device for a commercial case and ongoing use. So I think, from you and I, with users of experience, to be so excited with this technology, I guess for others, that says more than any words could. Obviously, with a practice similar to Sean's, we're also interested in having the technology and using and extending its applicability. That's not the forum to talk about how you could perhaps deal with some strategies with more complex anatomies such as neck angulation, but I think we're going to carry on with some excellent learnings with the device. And also, as I briefly mentioned, the use of the integrated balloon, I think will be a very important tool with things like acute aneurysms. So, but all of that is now that we've got this tool to use, is something we'll look to establish in the future.
Fantastic. Thank you very much, Drs. Lyden and Holden. Sincere thank you from us here at Endologix for making the time late in your evening, and I know early in your morning out in New Zealand, Dr. Holden. So we sincerely appreciate you participating today. With that, I want to extend our thanks to everybody that joined us for today's webinar. Hopefully the information we shared for you was valuable. Again, if you have any follow-up questions, please feel free to reach out to anybody here on the Endologix team or your local rep. Be happy to engage you guys in further information on anything that's been shared today. With that, I want to wish you a good evening, a good day, or a good afternoon. And thank you again to our speakers for joining us today. With that, we'll close the meeting. Thank you very much.
Thanks, everybody.
Yeah, thanks very much.